Exactly.
Yes. And thank you, Chair. And I'm going to try and talk even more than I have planned, bearing in mind that Lisa will pick up on quite a few things that will come through my reports. If you have read the reports, you'll see the two different styles of reports as well. So the April one was written in the old style, which I suppose Mark would say long-winded, and the May report is written in the 3 AAA style, so the advise and assume. But sure. That was a Freudian slip. And just coming up to what was said within the CAMS, I didn't ask the question, but I was assured from previous visits there, and they're an isolated service, but they are connected through the wider CAMS network for the sort of internal audit process where they look at each other's services on a regular basis. So, because that was something that clearly Rayside find very useful now, and they're looking forward in terms of their outward, in terms of their culture, which I think with these secure environments, we've got to be so mindful of that, haven't we? That there's that proactive external contact and refreshment and movement of staff. So I didn't ask them that question because I knew the answer to it, but I thought I'd say that now. In terms of the first report, again, I'm assuming you've read it, just to highlight the infection prevention and control item that we discussed. We did only gain limited assurance at that point, as we don't currently have a centralised overview across all our areas, whether they're inpatient or outpatient. But we noted the plan for a new audit oversight process of IPC and the proposed implementation of a live dashboard, which will help us as a community to see things in real time. We did review the clinical audit programme for 22-23, which sort of takes into account all the national mandates as well. We were pleased to see that, and I think the earlier staff group talked about that merging of quality improvement and audit and good practice, and within the trust, I think we've got something that sounds a bit weird now called QUICE, which I think is the quality improvement and clinical effectiveness described together. But obviously having the two together, even though it's a mouthful, allows for joint working and sort of addressing all the quality issues for us. And we just noted in the committee that there's been a great effort from all the directorates to ensure data is being collected and reports were shared with our high priority audits, and that we're going to next month, which is this month now, and get an update on lessons learned from the key audits. I won't talk about PSEP because I think that's something that Lisa will update us on. So that's the April report, and there was something just to escalate from that April report. It was just around how there was soft evidence through our networks about the impact of staff morale on that external messaging about the CQC reports and consideration of our comms in response to that. So obviously that was April, and things have happened since then. Coming on to the May report, in terms of alert, I think I'll leave the serious incidents to these. There was, we did note an increased reporting of physical assaults and prone restraints, and that has been a notable increase. And it's interesting that the FCAN talked about that themselves, that we have got a small number of service users who are leading to an increase in those, but obviously we need to continue to monitor that. We did have a discussion about our prevent training, and actually since the meeting I've had some conversations around some of our language within prevent training, in particular our use of the word Islamist in that, and whether as an organisation we could think about, even though it's a national mandated training programme, etc., and process, whether we can think about the way we use the language internally and whether we do need to get some advice perhaps from Jazz as to what we could use that, you know, clearly we still have to identify that and staff have to be aware of that particular risk, but how we can use that in terms of language. Is there anything else I wanted to highlight? Probably not, unless there's any questions, I'll leave it there.
Yeah. Right, I've got one quick question. So then the meeting night, April, I don't think I've attended, but Mount says that there was a detailed discussion of the insurance framework and like things we brought forward to the May meeting. I don't recall we actually talked about it at the May meeting, or maybe you.
You're right, actually.
Yeah. I just think so. For I guess for the next meeting, we just need to make sure that that's on there. I think.
Yeah.
Because I think my meeting we just ran out of time anyway.
Well, yeah, we did. It was a ridiculously long agenda, wasn't it?
Yeah.
I think next meeting is more manageable from what I can see. So fingers crossed we can do that. Yeah.
Are there any other questions?
So actually, it's just a comment about I think the use of the shore alert eyes. Was really helpful. I don't know whether you found it helpful as a committee chair needing to report.
I think it will be, especially as we have that in mind when we're in future meetings and what you note in terms of something on. So I think it will help the discussions and the sort of noting what's important as well.
And if I may interject, this is the first iteration of the use of the AAA
Yes.
form. And I think in terms of content, we don't need any additional information. This is actually sufficient in terms of levels of assurance that it's actually applied to the board. All what I will say is at the bottom of the form, it does say minutes are available. And we need to ensure that those minutes are available either in the reading room or on request if an individual would like to see the minutes of that committee meeting, that there are accessible as well. And that should be sufficient going forward. So the chair of the committee, this is their first situation of using the AAA form, which is circulated to the board, but I think it's much better. It's easier to actually see what some of the key areas of discussion are taking place within the committees. So if there's no other questions for Linda, Lisa, you'll have to make yours.
I'll try my best. Okay, thank you. So to run through the highlights of the report then, and I'll try and work through these at pace, taking the papers as read. Just to escalate to the board that currently we have 35 live SIs in the system currently, and that is an increase from last reporting of 14 incidents. And actually yesterday we agreed a further 4 SIs through our SI oversight group. And so that's a continued escalation of the numbers of reported SIs since December of last year. And I think we're trying to work with the standard of investigating these in a timely manner. And I'm pleased to report that currently only 4 of our investigations exceed the 60-day standard. So that's a reduction from 8 last time I presented to the board. And also the average time for completion is now 65 days, which is a reduction from 90, which is kind of evidencing the hard work of the team. I did want to note to the board, though, that with the increasing number of SIs, the workload on what is a relatively small patient safety team is significant. And given that, I did submit a paper to the executive team to ask for additional resource temporarily for the team. This was agreed by the executive team, but unfortunately, due to new NHSE rulings, we now have to submit a business case to the ICB and to NHS England, which does not a process currently at ICB level. And so that has delayed the resource currently.
It's that because it's based on the level of resource that you're requesting, and so
So there's a number of criteria which essentially for clinical and non-clinical posts, which is anything that's over 25 days, anything that goes up to a value of £400 a day. There's a number of criteria. Now, because we make it over 25 days, we take that criteria. So the themes that I reported last time in the SIs remain the same, so I won't go through those in any more detail. Just to touch on respect to our health inequality information. So we will plan to bring something to the board after July's report to QPS. That will give us some kind of broader suite of indicators around our quality metric information in regards to this. And we have started to do this with our complaints information, which you will have seen through the report. But the quality of this will improve as we kind of use this more usefully over the coming months. And we currently have 112 open SI actions, some of these dating back to 2017. So it's given a summary there by division of the kind of performance. And we can see that most of our open SI actions are sitting within acute and urgent care. And that's the area we'll be focusing on for some additional support from a team perspective. And we have got a plan of how to approach that. And hopefully when I come back to board, we'll be able to give you some good progress against that. I did want to give you some good news around our open investigation. So you may recall that we had a fairly sizable number of open investigations dated back to 2011 on our incident report system. We have reduced that since reporting to you by 1,753 incidents. And all incidents predating 2020 have now been safely closed. And so that just enables us as an organisation to continue the work moving forward, really. Just from a niche perspective, again, I went through a bit more detail last board, the niche reviews that have been undertaken. It's just to give some assurance to the board that now both of those niche reviews have got active action plans in place. And I'm sure, Steve, you may agree, we have quite a robust process in place now around how we are managing and monitoring those external reviews. I've also drawn some attention in the report to the 2 PFDs that have been issued since I last attended board, and we have responded in both cases, and the detail of that's in the report. From a PISA perspective, we now have reached phase 3 of our transition, and essentially at this stage, this is all about effectively understanding our data and to be able to put plans in place in regards to how we will work going over the next 12 months, looking at our safety themes and trends. So we've done that initial piece of work centrally, and we're now going out to divisions to understand their data from the divisional perspective, to start to get their view on how we want to proceed from a thematic perspective going into the next 12 months. So very much an engagement piece over the coming months. I touched briefly last time I attended around the safety summit approach that we wanted to take within the trust. Pleased to report that we had our inaugural summit since I last reported to you, and it was broadly very successful with 4 QI work streams emerging from that event. And we have had another specialist safety summit focusing on poziothene toxicity death, and that was chaired by Farida. And I think we've learned again some things that we can improve. We're evolving all the time, aren't we, Farida? But again, some really successful discussions at that summit. And then briefly from a patient experience perspective, we currently have 17 formal complaints open, and we're 47% of our complaints are currently awaiting an investigating officer, and unfortunately that's an increase of 9% since I last reported to board. The average case is taking 76 working days to investigate, and an average time of 66 working days to allocate and investigate. Both of these standards, of course, do not meet our best practice standards. And similarly to the patient safety team, additional resource have been requested and agreed by the executive team to support the complaints team in managing the backlog. But this is currently delayed as explained. However, we have managed to find an experienced person on the bank that will support some of this work. In regards to our complaints actions, it's a similar picture in that we do have a hefty number of complaints actions overdue, and a number of these actions are over 12 months in age. However, I identified last time the predominant reason for this is that our divisional colleagues were not cited on these actions and therefore couldn't be expected to action them from a divisional perspective. We've now created complaints trackers, and they've actually gone out at the beginning of this month. And we have meetings planned to go through these complaints actions. The first one being with ICCR, that's right, isn't it? Who predominantly hold most of the open actions. So again, I should be reporting much more positive position to board when I come next time. So I think I won't go in detail, but I've run through some of the early indicators that we found from a quarterly perspective. But as I say, we're improving our analysis of that. So I don't think it's massively helpful to the board today, but I think you'll have an improved understanding as comfortable next time. So I'll try to run through that. Thank you.
Lisa, thank you very, very much. Can I just open it up to the board for any questions?
Yes, thanks very much for that. So just on the form complaints, I've just opened pie chart up, just looking at the themes. I mean, 34% with communication with patient.
Yeah.
What are we doing on the ground around? I know there's a lot of work we need to do around the analysis, but communication seems something that we should be addressing and should be able to sort of fix. I thought, are we seeing a sort of a downward trend in terms of the actions that we're taking on the ground, or is that sort of consistent throughout the year? If that makes sense.
So the themes within that are very varied. So some of it is around, actually a limited amount is around the way of communicating with our service users. It's things like delays in letters going out, communication around clinics and different things. So it's quite broad actually. But it's difficult to pinpoint an answer for you in respect to that because there's a number of work streams around this, and perhaps that is something that we can detail better in the case so you've got an understanding of the work streams that are underway in those areas. That will give you a better idea of what's happening on the ground.
It's going to be good to know the sort of process versus training, for instance. So it's that sort of breakdown that I think be useful. And similarly, I guess for prescribing, some of that could be. I don't know, I'm not an expert, but some of that could be processed, some of that could be an educational thing. It'd be good to sort of try and understand that and really sort of get underneath the skin of that, perhaps. I don't know.
Our numbers are relatively small, so we should view some of that information with a little caution, given that the numbers of formal complaints are so small. So a small number of complaints will look like a large proportion, but nonetheless, I will attempt to give you a little bit more information around some of the work streams that are being undertaken.
That makes a huge amount better because I know you're already very strapped, but it's just nice to know a little bit more of the analysis, really. Thank you.
Yes.
One question, then we'll just a comment and a piece of post for So my two questions. One is around the consistency of themes in the SIs.
Yes.
And I'm just wondering, particularly thinking about risk assessments, care
Yes.
plans, things that And I'm just wondering, whether or not the committee has spent any time, thinking about, or having, a discussion about what the areas of work that are being undertaken around those. And the professional curiosity is the one thing that comes up, not just in the SIs, but it also comes up in sometimes in coroners and RCAs and other things as well. So it was just a question for both you, Liz, and for the chair around the level of assurance you've got around the work that's being done around those things.
I mean, it's very much work in progress, I agree. But I think we're getting more detail. The reports are definitely improving. As we need to refer to Steve, if you want to.
Yeah, I think the piece that coming along with our approach, safety standards, and that's where we're going to really take a little work around some of those consistent things, and then we can deal with our policy for international issues. So we get to the next few questions. I think that's where we start to get as part of work and wonder this, you know, what gives them this chance to see what you next time would and it's.
And the second question is around the incidents. It's great to see that the number has reduced. And I just wonder whether you've got a sense of the trajectory of when you're going to close off those as you need to be closed.
Yeah, it's a very good question. So I think we'd hope to make some more traction on the 2020 incidents. This has been led primarily by the clinical governance facilitators that are working with Julie from Arno. So I think there's been some, so there's definitely been progress. I've seen the thematic reviews being sent to the divisions, the 2020 incidents, but we're awaiting a response from the divisions on that. So I think if I could possibly, outside of the meeting, get some of your help in just getting some of that response, and then on to 2020 plots then and things. So I think the work's been done. I think it's just that responsiveness, because we didn't want to lose the learning from those incidents.
Yeah. Only if it's helpful to such.
Yeah.
Again, it might be something the committee might want.
Yes, of course.
And then my third point was about the publication of the niche report into ZN in particular.
Yeah.
Very conscious that that will be published in July.
Yeah.
And that it will attract attention as part of that. So I'm just conscious that we need to take an action for ensuring that the board are up to speed with the action plan that you described, and receive that and receive the outline areas report in advance of it becoming public. Again, an action.
I think she's full time. The first publication of how to make a decision on the potential interest. Yeah. Yeah, thanks for just taking the inequalities there. It's helpful to see that, you know, the first time we included the complaints and the protected characteristics. Just wanted to check whether we sort of routinely do the same about incidents.
So that's the plan. So the quality metrics associated with patient safety are much broader. And so we started this work, this work a good 6-7 weeks ago, actually. So that's why we've said we'll present it quarterly, and that gives the team some time to start to pull all that data. And so we expect it to be in July's report to QPS, quarterly report to QPS, which will then be able to.
When I joined the organisation, we had all the characteristics based on national and protection parameters, so we would then better that on 40 days. Okay. Any other questions for Lisa? Lisa, as always, you present a very detailed and comprehensive report, and it's always, I say, a pleasure, but it's always good to see the level of detail that you provided here and how the trajectory we're actually reducing, particularly the number of cases that have been long-standing, you know, over 12 months. There's been a significant timing with those for some time, and they're slowly coming down, so it's great to see. And again, thank you very much for your report.
Thank you very much.
Okay, so we move on to the Mr. Chair's insurance reports. They do.
So you're going to do the ethical one, or do you want me to combine the two? Combine the two, okay. Thanks very much. We have a question in that Monica chaired the April meeting and when I was away. And apologies that there isn't a main report, and I haven't been able to quite get into the groove of writing the new report yet, but we'll get that done as soon as we can get that shared. So combining the two reports, overall we received April was a deep dive, so we looked at the workforce plan, workforce development plan, specifically the strategy, and there was also a detailed report around safer staffing. And then in terms of May, we had assurance reports from shaping our future workforce and transforming our culture and staff experience subcommittees, as well as the quarterly information. So I'm kind of using the information that came through those reports just to pick out the three key areas. And I'm sure Patrick will want to expand on that at the end potentially. So in terms of things to alert the board to, I think there was some concern overall that the pressure of staffing and our issues in relation to vacancies and absence from work and our ability to fill shifts was impacting on the well-being of our colleagues, in the sense that they can't access very easily some of the key things that actually are about us supporting them effectively, and most particularly, I think, looking at doing staff appraisals and getting those done effectively, because that's all about understanding what their needs are, and also attending the core leadership programme, which is a very important leadership programme the trust have developed with a number of places upon it, but we're only picking up half the places at the moment because people aren't able to get to that. So we did have a conversation about what our approach to that might be, and the view was we should try to work really hard to get people to the training, because in the end it's about their development, it's about the leadership of the organisation. It's kind of core to our improvement and development. So real focus on that. Obviously, we've had a conversation about safer staffing, and within that, the confirm and challenge work that's going on at the moment. But we did query whether the pace around the development of the 6-week e-rostering was working at the pace that we wanted it to, because that's part of picking it up through the challenge. And there was quite an extended implementation for that. We wondered whether we could pick that up a little bit, and I think Steve took the role to look at that for us. In terms of alert, we were quite concerned in terms of a couple of issues in relation to black and minority ethnic community colleagues in the organisation. One being that in terms of the recruitment process at the moment, the numbers actually being shortlisted in relation to new appointments had reduced to quite, to a level that was concerning, and so we need to do something to address that, to make sure that we're picking that up appropriately within our strategy overall. And similarly, in relation to the workload or the number of cases that are in process in terms of disciplinaries or policy implementation, there were a proportionately higher number of people from those communities in that group as well. So clearly there were some issues that had gone slightly off kilter there that we said were quite concerning, and we would want people to be looking further into that and making sure that we're picking up those as key issues to make sure that they're fair, right and appropriate in terms of our anti-basis goals. I mentioned it earlier, and we did approve the annual plan of goals, but as an alert, we did say that we were quite concerned about sustainability. There are a lot of people, strategic priority goals in there, a lot of them, a number that have extended from this year into next year. But we're quite concerned about resourcing the ability to make some of those changes. And so we asked that a review of that, consideration of that could come to us, because I think it's really, when you put that with the ambitious requirements of the workforce plan over the next 12 months, there's quite a lot of work involved in doing some of that work. And actually we were quite concerned for our colleagues in the People Directorate, but also the organisation more broadly, in terms of being able to get the support to make those changes. And we felt that potentially should be considered as when we're looking at the BAF and the risks coming through that discussion, that should be something quite significant, because we may need to do something about it. In terms of advice, we had a really heartwarming presentation from a doctor that came, a senior doctor that came. She'd worked in the organisation for 10 years. She was talking about the opportunities she'd been given. She spoke very, very highly of some very specific individual senior medics, which was, again, heartwarming to hear. But she did balance that with very candid conversations with us about the challenge. And actually, you know, not everything can go well, but actually we need to work together and work effectively. And how difficult it is to recruit people because of the challenge of working in what is specialty services often within our trust. So that was really very heartwarming to hear, kind of that balance, really. So that was good. So then in terms of assurance, and I think this is, it was particularly pleasing for me, probably, I should say personally, to hear this, but because we'd raised it through the NEDs, had raised it specifically of things we'd heard from colleagues around availability of avert training, and it's been increased, people are getting through. So it was good to see that we'd heard it from colleagues out and about, we fed it back, and now something had been done about it. So in terms of the loop of, you know, people are raising issues with this and something being done, that was great. So it was also good, obviously, because that means that more colleagues are able to operate on the wards effectively. So that was helpful. Sickness rates continue to reduce, and particularly pleasingly in relation to some of the anxiety, mental health, wellbeing type areas, which was pleasing to see. So hopefully we can keep that in place, and hopefully some of our support mechanisms are supporting that. We had an update on the staff survey work. There's been a lot of discussion with the organisation, both at team and divisional level. John Travis is doing a lot of work to get out there. I mean, he just feels like a little bit of a one-man band getting round people, so operating a lot, but pulling up what he believes to be some really, and help develop some really good plans for improvement there, right at a core level, at a team level, which hopefully will build a mosaic of improvement across the organisation. And actually, what we thought was it really was a really good example, another example of us trying to turn into that listening organisation, listening and learning organisation, really, by hearing about what is it we've got to do to change those areas. And then just finally, we had an update on international nurses. We'd had some challenge from some of the governors, frankly, on that, which was, you know, helpful. And we had a detailed report, but what was pleasing from that was we heard the trajectory. Well, the trajectory we're working on at the moment. Clearly, there's more fallout than we thought there was going to be in terms of people coming through the system, because there's a lot of people in the system, but as they're going through for a variety of reasons, and I'm sure perfectly reasonable ones, when you're travelling halfway around the world to come to a new role, people are falling from that. But the current hope is that we'll have about 35 by the end of October. And what was really pleasing with that was that there was a concentration in terms of the report on the pastoral aspects of bringing people, welcoming people into the organisation, and the layers within the overall system to support them as we're coming through, including things that we're doing from an educational and support basis. There's a fantastic handbook actually that someone has produced. Yes, off our own back, really, frankly. We have, we do need to kind of. Can't remember the lady's surname. Fantastic thing. It's being used as and promoted elsewhere in other places. So really good. So we're bringing folk in and we're supporting them effectively. So that, I think we've got that rounded approach. It felt like a rounded approach to it. And what we just need to hope is that people will continue to come. July's the big month. We get 10 in July. So hopefully if we can hit that button, that'll be a good step. So slightly more, I know I've spoken more than I'm supposed to be aligned to anymore, but on the basis there wasn't a report. I'm using it as an excuse to keep talking. Thank you very much.
Thanks. Any questions?
Just to tip this up, we didn't get the May report, but in the April reports, and they were saying we've got limited assurance on the sector staffing reports.
Yeah.
I wondered whether in May we get better assurance on that.
Well, we didn't have a safer staffing report in May. We'll probably get another one it's next month again, isn't it? So we're not having them every month, we're having them every other month from our point, from a people point of view, because it relates to the safer staffing rostering and lead rostering work as well.
In terms of the window, so we've second of June, so that's just to call, we have the BMO sign up in terms of our safety care rollout, and also just ensure there's a process around check and checking the rosters. But clinical needs starts all that they start beginning of July, so we are trying that in terms of the PMO approach to it rather than the trying to galvanise and do a dictate sort of real approach or program on how to roll this out. And so steps recovery ICCR Thursday will be rolling out this process so we can continue to evaluate where we're at.
Okay, thank you. I've got one more question,
Okay.
which is also on the April update. It's about the review of the board assurance framework. Had a detailed discussion happened at the meeting? Because it says again that we brought forward to the next meeting.
No, and we didn't have it in the May meeting with us.
Yes, so we didn't have it, we just had an update that because of the ongoing piece of work around the reviewing of the strategy, we had to pause that piece of work to wait to align the path with the new strategy. Otherwise, we had to duplicate it at the moment. There was another very emergent element which came up at the last people committee, which was around the welcome pack we have of our international nurses, around the concern that some of the governors raised around support and pastoral support for international nurses. And Hannah did share with them the welcome pack, which at the moment is one of the best within the footprint. And some of the partners are pinching and using it as well. So it's very important that we know that very positive.
Yeah,
Yeah.
that's fine.
Great. Well, I can then speak this up unless you want to choose to respond to that one. You can go for it. So the international investigators nurses outfit nurses arrived actually today with a further 6 planned to arrive in July. So the numbers will build up in the next 4 weeks, and that's going through some of the process that we've had to learn about with IEN so quickly. Sharon's and the team's kind of pastoral care package. Not only that, just seeing them to ask Sharon a case study on how she implemented the change within the organisation. So it's also been taken onto a different platform in terms of that change management process and how what Sharon has learned in terms of some of the obstacles through the NHS to actually understand how we can roll out change across other elements as well. Excellent.
Mine was just a point of clarity for myself really. Earlier you said, Chair, about putting together the learning from the staff stories in terms of, what kind of things there might be. Obviously, we have staff stories that are different as well. So are they going to include it, or were you referring to kind of just what the staff stories that are presented in the report?
I think it could be.
Because I think it's good to include the committee ones as well, because we get like a breadth of kind of information.
I was just waiting, sorry, Kevin, this, I knew that person, I was pushing a bit, but colleague she joined the organisation today, but I was actually educating those.
Excellent, excellent, well done. Are there any other questions for? Okay, coming to FPP.
Okay, thank you very much, Chair. Thank you. Both reports have read, I'll summarise both of them in one go, if that's okay. So the trust submitted a financial break-even plan to NHS England. Our month one outturn is a deficit of £59,000. That's mainly down to run rate pressures, which includes a slippage on recurrent savings and ancillary expenditure, and also temporary staffing. So our agency bank year on year is very high and continues to sort of trade upwards, keeping on it, David. So it's something we need to keep a very close eye on. So that's something that we're going to be tracking very closely going forward. Just on that note, I had a conversation with Richard Solers, and just sort of, I know it's a blunt tool, but what I've asked him to do is to look at our year-on-year sort of pre-COVID, during COVID, post-COVID levels of commission work income that we had versus our costs, so staffing costs. So if our commissioning has increased by 10%, in theory, our staffing levels, you could argue could have increased by the same level. But if they haven't, you can start to sort of look at the data and sort of ask the more sort of inquisitive questions around that. So hopefully at the next meeting we'll start to see some of that data flowing through, so that we can then sort of look underneath the skin of that. We reviewed the performance indicators. No real significant changes there. In so much that we've got a lot of clarity now in terms of the Get Well plans. Obviously, the sort of the forecast trajectories. So it's a case of just a watching brief around that. Much similar to the point that Anne made, we looked at the sustainability strategic priorities and the clinical services strategic priorities, and we improved them. Notwithstanding the conversation we had previously around sort of the actions around impact and how we sort of bring all of the strategic strands together to drive a much more perhaps transformational agenda going forward. What else was there? We approved the business case for a new provider collaborative in perinatal services, which is due to go live in October. We are going to be discussing this in private board, so we're still sort of the thread there as well. But in principle, that was approved. But there are a number of financial considerations we need to sort of debate and get through between now and October, and sort of our potential to deal breakers. Yes, so that's understood. We had an update around the digital strategy from Carl Beats, and we were pretty well assured around all the work that's going on there. What else was there? That was about it, really. We agreed to format our self-assessment effectiveness survey going forward. Yeah, that's essentially a summary of where we are.
Thanks, Phil. Are there any questions?
I've got a question as well.
Please start.
Just to build on what Ballard said, just around the agency and the bank spend, we know that's been going up. So Richard, Solers and myself have been doing some deep dives with some of the divisions. We've done a deep dive with secure and offender health and acute and urgent care. So it's just the highest spends. I'm really interested in really gets into into the grassroots of where some of the challenges are. So for example, not reaping all of the the income specifically in the secure and offender health force, especially that we do with staff. But so that was a bit of a shortfall, so there's a bit of work around that. They're going to put into place both of the divisions and further challenges with their staff. So again, going down to team manager level, just really getting into, like I say, into the grassroots of some of the challenges. They know they've been overspending on some of the wards because they've got too many staff there around the establishments. That goes back to the in-house work that we're doing. But they found it really helpful, really supportive. And again, they ask, what can we do better? How can we help? So they want some more training for their staff because they feel that focusing on the budgets has probably not been a priority because of COVID. They were looking at sort of clinical safety, but bringing that management sort of skills around budget management and sort of savings back into the arena. So just wanted to share that we're doing that work. We've got the other two divisions to do this month, and we'll probably do a bit of a summary around some of the themes, and then we're going to feed that back through our local deep dives that we do into the divisions, but also through to performance delivery group as well. So if we give some influence to the board that we've got sight of that one.
That was really good to hear, and it's helpful to note as well the point that you mentioned about training managers, but I've mentioned.
Yeah.
I was going to pick up in the chair's report earlier, which mentioned about sickness trajectory is that it is actually coming down, and how that then correlates with temporary staffing in the agency and bank spend, because obviously to me there's green shoots that people are feeling a little bit more confident about their work, maybe feeling supported by their employer, by their manager and so forth. And that may then, I'm not saying that's just one indicator, but obviously it's something to actually note, isn't it? That if the sickness rate is actually coming down, how is that having any impact on agency and bank usage as well?
Yeah, I just wanted to add to what Vanessa was describing there, which was part of actions what we have talked about in the FPP quite a while back, where the conversation was about what we need to do from a people perspective in terms of the increase in the demand, and being very clear that this is not about turning off the tap. It's about understanding the demand, because when we look at the data about the request for shifts through TSS, we're still not able to meet that demand. So we are below the rate for providing. So as much as we are reporting about the increase in spend, if we'd actually get that demand, that's going to be much higher. So in its understanding that level of demand in terms of the activity, which is the work that Vanessa and colleagues are doing. So just wanting to triangulate that in the workforce perspective.
And that's why I wanted to kind of get an understanding of what does the demand relate to?
Yeah.
What's driving it?
Yeah, again, they're the questions that we've posed. So we heard, some of those reflections from both the divisions around acuity. That was the main one that, someone may be admitted to the ward and they may need 2 to 3 levels of staffing just to help and support, particularly at elderly. Yeah, absolutely. But elderly, they're very much talked about, they feel they've got great because some of the staff have come back from long-term sick, some new staff have started. So again, when I was speaking to Emma, very upbeat around we're moving forward. So that felt really good because elderly has been sort of under the spotlight and quite challenged. We're not out of, we're not out of it yet, but you can see there's signs of recovery there.
Yeah.
So that's good.
It'd be good for thanks for that. It's good. It'd be good to triangulate what we just talked about with the very sort of high-level, as I say, blunt data that we probably get and sort of see how that numbers up. There was one thing before I ask my question. That we got some nuances around inappropriate bed placements versus bed days, and how that impacts financial finances. Would you like to just explain that sort of clarity?
So the performance metric that we used back in Hurricane Academy said at time people go out of area for the appropriate times. So we're measuring that. financial implications also are around appropriate emissions over that that's funded. So we've got two things that we need to monitor. We need to monitor the spend against the available funding, which is the financial side. That's greater than the issue. So we're seeing improvements on the out of area in appropriate place, but we're still a little what we're funded for. So it's really important to monitor both of those.
So I guess point that is hopefully we're going to start to see more sort of clarity around the data into the report. My question was again around the break-even position that Birmingham Solihull ICB put in. I read a HSJ report which showed all of the other those ICSs that submitted a break-even and those that didn't. So you've got Birmingham, so you've got Black Country, who absolutely look like an outlier in terms of the amount of deficit that they're posting. Now, in my mind, that is an indicator to me of that ICS's risk is Birmingham Solihull. Being an adjacent ICS, would that impact our ability to work with that ICS? Or does it not matter?
I think it can impact because of the fact that we obviously share some populations. And actually, at least one organisation in that country is part of the two ICSs. So they sit in both spaces. And that gives us though the opportunity to really think about and a better understanding about the decisions we're making, the decisions that we're making on a really understand some of this. And obviously our regional colleagues were really clear about wanting to get all of the Midlands to a break-even position. And I think the impact is really great for the country. I think this point about anyone that isn't paying because of getting financial plan is going to be subject to greater scrutiny and just about anything. And that will impact on how care is given, it will impact on their ability to move forward on a number of issues. And it's one of the advantages that us taking the decision we did about there's a huge risk associated with our break-even position, but there was a huge risk of not having that break-even position about being able to take forward and things. So.
No, I just want to ask the question because obviously if all the spotlight's going to be on that particular IPS from the centre, then their ability to sort of look, broadly becomes a little bit.
You would think that, wouldn't you?
Yeah.
I just want to comment. So I think the HSK Journal said that 14 of the 42 ICSs submitted deficit. So, yeah, I suspect we're going to 28 are managing risk. Significant risk. You can go two ways, really. Unfortunately, when I was an NHS Funds director, I had to submit deficits at times. And sometimes if you go bold and straight and you say this stuff deficit, these are the reasons, you'll get scrutiny, but you'll get help first. If you hold back and you have an underlying deficit, you say we can somehow manage it, and it emerges later in the year, you're often in the worst place because they've helped everybody else. The money, the cupboard's dry, and it's something.
So that was addressed by NHS in this round.
But I do want to go on to our position, which is that, and your report says it in April, was that we'd initially submitted a plan of a £3.1 million deficit, and we brought it back to break even, or I don't know what the nuances of that were, and our month one position showed a deficit. And the overall deficit we're showing is a netting off of the retail surplus and the SSL surplus. So I'm kind of worried that our underlying position is worse than it is. And I think as a board, we just need to now understand what if you like, what things we've got in cupboard to help us. You need to get that. You may not be able to answer that in full today, and that's fine. But I think as the year emerges, we'll need to understand that, won't we?
I think when we talk about plans, brilliant. So if there's elements of mind.
I think it is important though to do some reckoning is that the point you made about the traditional position, which was that you held out and you were really clear about you couldn't manage the risk of got support. That was addressed this time around, so obviously we're really clear that that support wouldn't just go to those areas that actually it would be proportional if any new funds became available, or the ability for them to support the managing of the risk
Yeah,
became available.
that's helpful.
Oh,
Oh, no, it's fine.
okay. Are there any further questions for, well, if not, we'll move on. Okay. We've got people from this one, so it's great, so it's base finance.
So I think of what you said first was, so the move from the 3.1 to the break even. Largely the ICB has handed out further income to all providers. That means they've offset that by a recurring risk reserve at the centre. So they're putting a negative risk reserve. So effectively they're saying, we'll sort that out, your marketing. So there is a risk in this situation. In addition, as part of the overall move of being sold, there was further funding coming out for non-pay inflation. So for things like PFI, etc. I haven't got the full detail of that, but there was some of that coming through. There were a number of other adjustments. So we went through that at FDP in overall terms. When you look at the overall scale of income that comes in, the 59k is extremely low in the overall, but there's all the fluctuations in the different areas. So you have got, as you've already said, we have got a deficit in the overall group position, which is made up of, you've got it there, split between the provider side, the two provider collaboratives, and SSL. There is variation on each of those, so we do manage that and we can go to the overall level. At this stage, there is flexibility still within the balance sheet and with other organisations to manage their own position. So we're going to work that through over the course of the next month to say actually what that looks like. I think Val's already covered the financial position. There is a type of report, it talks about service 49k, should be a deficit of 59k the first month. So at this stage, we have got problems, as we've already said, around our area, temporary staffing, and the recurrent savings delivery that we knew were risks that we go through. We need to make sure we've got improvements around each of those and we're clear about actually what that level of risk is coming through around it, and we'll do further around that. The work that Al's talked about in terms of dealing with pre-COVID, during COVID and now comparison will be helpful. And it will say something about staffing, because there is perception in some areas that actually, as a result of COVID, we've got used to different levels. I think the same staffing part is the only way you really get the truth around that. The capital position, it says £500,000 on first plan, that's ahead of the plan. So the problem is always more, we're in risk of not spending it. We're spending in advance of that, there isn't really an issue in that. Cash, we're awash with cash, which is the first situation, because we can't spend it on capital. We're not allowed to the way these things are done. So we've got 68 million quid in the bank or half a brace, which it's absolutely golden. All the trusts are exactly the same situation. So UHB got significant funds held that are not going to spend on capital. We've explored in a number of ways things that we can do about trying to address things like both Braeside and Highcroft, etc. But there's some innovative approaches around that. But it's also, we've got an approach, certainly for Highcroft, about an incremental move through, trying to increase capacity. But we do something similar on Braeside, but it's also on main. It's decades out of date where it is. We're going to waste money on that area, just keeping that fit for purpose open, but we know that. One particularly going to say more than that, I've got to answer any question about it.
One quick question I had, which is on the efficiencies. So at the moment, for the programme for the year, which is 14.7 million, but we've still got some unidentified.
Yeah.
Figure of 2.4. What kind of process are we going through towards making sure that's identified?
We're trying to identify at this stage, but we haven't got confidence we are going to identify. It's inevitably there's an impact on services. We'll always try and address that. It's likely to be, and other trusts will do the same, it's likely to be they use balance sheet flexibility to do that.
And a quick other question on the area, because this is slow. Because there's a line in here which talks about budget setting pension review. So I presume that our pensioners or people that are going to be affected by that. So I think it's a 1.4 million potential saving.
On its impact on individuals, it's probably more about the allowance that goes into that. No, you can say
Yeah.
it's very high.
Yeah, sure.
Any other questions? I just like one. It's about inflationary pressures, and just wanted to find out if we've actually built in non-inflationary uplifts into the budget. Where we go through contractual mechanisms, have estimates being held in reserves to actually cover potential costs that arise.
Yeah. So effectively, we're getting allowance for so much inflation, which isn't necessarily what the real cost is going to be. So we also know there's that both pay and non-pay, there's a risk of either way around that. We release the inflationary reserves as a mandatory value. So for instance, when the pay review gets finalised, then we release it from the sense service. This process of you put it at the centre until you know, then transfer it out to the individual area. We continue to review that. Inevitably, what's allowed for inflation from the centre, it's always a little bit off where you're expecting to be. Sometimes again, usually in the summer.
Thank you. Thank you. Thanks for that. There are no other finance questions for Dave. Then I'm just going to juggle the agenda around because obviously we're really pressed for time. We've got a couple of our colleagues outside that are waiting to present their reports. So we have Emma, who's outside, and she's going to present the food speak of reports. Yes, and then to come in, and then after the quarterly instead of working report as well. So I'm probably going to, in terms of the transport forms reports on there, but unless people have got any specific questions for Monica, if you haven't, then probably we'll release you on the to get passed over. Where that's concerned, the audit assurance report. If members have got specific questions in relation to that, well, we'll just unless you've got a question, please let me know. Otherwise, we'll take it as an accepted read. It does. Great, welcome. Hi, Emma. See if you can find. It's always a pleasure to have interview to have Emma to present the report and to just to hear how we're doing in terms of our freedom to speak up. I know that I was asked to be a part of the campaign with the video. My video was taken, but I was 100% supportive of trying to ensure that as many people get to be about the good work of freedom to speak up and actually very much that will become champion possibly can. So over to you.
Good afternoon, colleagues, and welcome. It's great to be here. I haven't actually presented in person before, so this is quite an novelty, isn't it, for sure. So I accept that. I hope that the papers have all been read and it's welcome an opportunity for you to ask questions or any thoughts, reflections after I've presented the most salient points of the report. So in terms of activity then, this is a report that reflects the activity for the last board report last year. You'll be aware that in the interim we do provide updates to the people in this. We're still very busy, which is very encouraging. We had 89 concerns, 89 inquiries from the period January to March, which is our quarter 4. And 33 of those inquiries are actually in the formal process, so they are being progressed in the system. And once again, we find that it's our nurses that are our colleagues that access us more frequently than the other professional groups. But we are seeing that we colleagues are represented from all professional groups across the organisation. And encouragingly, we do have our medical colleagues that bring concerns as well as, AHPs and administrators and so on and so forth. So we're quite confident that we are reaching all those professional groups. So the report goes into some detail about the types of concerns that we hear. So at the moment, we categorise the National Guardian Office, we categorise them and sort of group them together. Worker safety and wellbeing is probably the highest amount of concerns, and followed by an appropriate attitude and behaviour. Encouragingly, this month bullying harassment is lower than it has been, and that's following directly from last month. So whether or not we don't know what that's about, whether people are not speaking up, or whether it's difficult to make that analysis. So in terms of our activity then and our business plan, we're really thrilled that the board approved our expansion of the team. So I've just written a job description for a band 5 colleague to join us. Who will be very visible, working within teams and helping support improve speaking at landscapes and local level, which is something we Lucy and I just don't have capacity to do. So that will increase our capacity, hopefully, and put us in contact more with areas that need support. And just going back actually to characteristics of our speaker, it's really important that we make sure that we are inclusive service. So we are encouraged to say that there's the portion of our speakers that have a minority ethnic group is 27 mark concerns. People with a disability is 9, and then people with identified LGBTQ is 3. And then obviously the largest portion of people, those that don't have a protected characteristic, or we don't know about. So, we're quite confident that we're reaching our equality groups there. So just a little bit on learning, because obviously Freedom to Speak Up is all about learning and improvement. That's what we're here for. So we encourage our, we're very confident that we are, action is taken, that we are able to draw and seek any learning from any of them concerns that are addressed. So we're working with our patient safety teams, and some of the patient safety concerns are actually featuring or being fed into the safety summit approach, which I think you may have heard about before. That's good. So that means that we're able to feed into that learning and that sort of multidisciplinary approach in local areas. And we've also forming part of the Justice Culture subgroup, the PSL work, which is important. That was a requirement from one of my board meetings last year, that Freedom to Speak Up becomes embedded into the new PSL. And we know from the recent CQC inspection that there are areas that are reporting that are familiar with Speak Up, but there are also areas conversely that aren't. So we're working in those areas. So Dan Meaning House, David Bromley, we have areas that aren't sort of, haven't had much contact with them, but we will be going out and working with them and providing services and drop-in to increase accessibility. And also we are going to contribute to the Oxford Trust Review to the Oxford requirement. It's a really important piece of work, because that was a key thing running through the inquiry in the Tony services, that the staff were reluctant to speak up, and then there was the fear to raise concerns. So we'll be contributing towards that in terms of the Trust's response. One thing I would like to request of the board is, one of our recommendations is that we ask all our associate directors and their direct reports to complete our modules, so speak up, listen up and follow up. We've already, as directors have already completed this, so we're asking their associate directors to do this, because I think this will ensure that they have full understanding of speaking at process and reinforce the importance that leaders have in speaking culture. So access to this training is available on the Just Learning Zone, and I looked at the providers yesterday, so we have 77 people out of a population of what we are 4,000 are we now, so you can see that, you know, the approach of it, you know, the really great if you undertook the training, just isn't how much in that direction you can create take of that. And so I'd request that board consider that recommendation.
Okay, open to questions, so Rashid, please.
So, a really important, really helpful to some of it's hard read, some of it's encouraging. So thank you to you and obviously down to encourage so many people to do it, but also to support them with me. We understand how intense the work can be, especially in these cases. Progress that you've made. I've got a couple of questions, and then I just wanted to reflect on the recommendation that you were making. So the protected characteristics of those is still significantly, most people don't provide it.
Yeah.
I'm just wondering whether you had any thoughts about what more we could do in the short conversations with individuals about why it's important to us and how we use it. And if there anything more we could be doing to.
We definitely need to look at that, because you could see that's a big proportion, and I think sometimes that's because we may just have a phone call with somebody, and it may be a conversation that's really distressing, and they're distressed, and it doesn't, you know, doesn't always feel the right time to ask that type of information. So I think there's something about the nature of conversation. But I do, you know, we encourage people to, you know, when we have a need of the person, it's easy sometimes to ask those questions, or we haven't seen people, but I appreciate that, we're capturing all that, and it's important for us to understand that. So we'll go away and think about ways in which we can, you know, increase that information.
And we can obviously help with putting together a narrative that we could also use in other settings as well. Follow up with people and say, this is why it's important, this is what we can do when we know this information. And my second question was about whether or not the questionnaire that is sent to people about their satisfaction or otherwise. In the boots at the moment, it's a question like if you aren't, you know, if you weren't and you weren't recommend, why not? So again, we could start to get that information about that. There's very small numbers, but just to get that insight as to, because it's, you know, it has every potential, it's got nothing to do with the approach that you're using to it, but actually how we might handle it as an organisation. So there's more learning, I think.
Accept that, and thank you for that. That's the idea. It's really important, because you'll see in the report that we obviously take figures, but we also take qualitative analysis. It's really important to us to have feedback from the service that we do find. So I think that might be an opportunity to ask them. It's a really tricky area, because I know we still don't use trust in other areas to capture that information. I think it's worth looking at and putting implementing that. And unfortunately, we don't have a large uptake in our feedback. When we ask for feedback, it's 3 months after the case is closed, and that's because we monitor any sort of repercussions and concerns raised. We can then report that information on. Then there are some arguments to say we could then go back and ask people again, because, you know, detriment just doesn't happen in the 3 month period, does it? Sometimes it can happen a lot longer, so it could be that actually we go back and we follow up that, because I think at the moment it's probably only something
like about 25-30% response to get back. So, yeah.
And then finally, I just wanted to reflect on your recommendation about, and I think we should, you know, commit to something to this. Because to undertake training, because you realise that's elements of it are helpful elements of it, just are just need to go through the conversation of doing it, but it's certainly it's thought provoking stuff. Definitely take that on as an action.
Patrick and then Peter.
Yeah, so thanks for the paper, and it's really good to see as well that compared to last year, the numbers have gone up. I just wanted to check specifically about the type of issues raised, where we have allegations of bullying, harassment, to include racism, whether the issue is people presenting issues around racism as bullying, harassment, and why it's not recorded separately, because we have seen cases where racism is kind of hidden in other things. So I just wanted to understand that.
Yeah, I think maybe that's about the way in which we capture the information in the National Boundaries Office. Because it asks us to call it any inquiries that include allegations of bullying or harassment. So we would then break that down. Once we've heard what the concerns are, we would then break that down and we'd be able to say actually within that might be a general allegations of behaviour within that bring part of this racism. So we draw that out from the case. And that's why we put it here, but the National Violence Office to record it separately, we would record it as themes.
So does that mean that we can record it separately?
Yes, and I do point, but what I could do is to improve it is to, so say we had 20 allegations and I come back with figures and say, well, actually 5 of those are actually related to racism. Do that, I could draw that information.
Thank you. Peter.
Yeah, just 2 things. I think it's really good that you had 3 students come and speak to you as well, so that's impressive. But I wondered if we can use your learning and share it wider and do it in a very safe and anonymous way. Because it's usually the stories of, this happened to me, I spoke to somebody, it got better, patient care got better, and that's really powerful. And I'm just wondering, you've had 18 and how can we use them either as leads or individual stories to then, we can talk with the map or the feedback. There's lots of different groups and even in our senior leadership meetings about actually what did make the change, they spoke to you and then what happened. And then, so then we can actually prevent things from happening.
Thank you for that suggestion. Love that idea. I think we have to focus on case studies, that type of approach before, and that's something we need to increase. I think so we've only done one case study, and I think once we have our new got all capacity in the team, we'll be able to do that a little bit more systematically. But thank you. Really helpful.
Okay, I'm going to have to kind of draw an end to the questions only because we're really good for time. Sorry, everybody, but we do have Emma's contact details if you want to ask further questions to do afterwards. Very conscious that we've got. So wanted to thank Emma, and this report was great to actually take from here, and also really encouraging to hear that the establishment and the team is increasing. So hopefully that increase will have an even more impact to see more cases and getting the detail and the robustness of that detail presented in the report, which you have done. So thank you for that. Thank you, Emma. The regarding our safe working before.
Thank you. So good afternoon, everyone, and thank you for welcoming me to the first board meeting as Commencement Post as the Guardian of Safe Working. It's the first time presenting these quarterly reports. Much like Emma before me, I've just that the reports have been circulated and been read. Hence, I wanted to kind of focus on a few of the salient points today. Given that we're covering Q3 and Q4 in the report presented to the board today, I think it's first and foremost important to highlight the increase in exceptional reports that have been raised by our postgraduate doctors in training Q4 compared to Q3, so from 2 up to 21 in Q4. This is a significant increase, and the vast majority of those reports relate to working hours and consecutive rest achieved by our postgraduate doctors in training at night. We are confident that the increase in reporting does not necessarily reflect a change in the workload of the trainees, but more a positive shift in reporting culture amongst our postgraduate doctors in training. And this has been the result of an ongoing quality improvement project, which is led by our trainees, as well as increased visibility of the Guardian Safe Working and outreaching to our trainees to make sure that they're familiar with the processes. The increase in reports, though, has contributed to an increase in delays and those being processed in terms of the amount of time that it takes for the supervisors to go through those reports. The increase in reports does increase their workload. The vast majority have gone to the tutor for our higher trainees, so our ST doctors, and there is a new ST tutor in post as of May, and I've been working very closely with Dr. Campbell to ensure that she's very familiar with that process, to ensure that we can hopefully get these delays reduced moving forward. We also, as a result of the exceptional reports, there have been more fines levied against the trust by the Guardian Safe Working. This is due to the Rota rules and the requirements that are in place that doctors working out of hours must achieve 5 hours consecutive rest between 10 PM and 7 AM when they're on call. And in 10 cases in Q4, this was not achieved by our higher trainees. As a result, there have been ongoing discussions between medical workforce, the Deputy Medical Director for Workforce, and myself, as well as the Associate Medical Director for Training and Education, to review the rota patterns moving forward. The last meeting was on the 24th of May, and we are having ongoing discussions with our ST doctors to reach an agreement about changes to their working pattern moving forward, which we hope will address the exceptions that we've received. The final point that I wish to kind of raise to the board is the number of vacant shifts for our doctors, which remains really very high, with an increase in Q4 compared to Q3, with over 500 vacant shifts in Q4. The vast majority of these gaps were due to vacant posts, actually, although there was some additional pressure in terms of vacancies due to the industrial action by our junior doctors in March. It's positive, though, that all of our on-call work vacancies were filled during this post, almost all by internal locums, including when the medical workers team offered prospective cover, which was paid for all of the vacant shifts during the industrial action period, which was total to 48 shifts. What I ask for the board today is that there is ongoing support from our senior leaders to continue to encourage the culture change which is happening within our postgraduate doctors in training cohort in raising concerns using the exceptional reporting system. And I've already had some discussions with the leader to see how we might be able to do that through written communication with our postgraduate doctors in training, both now but also at each rotation.
Thank you very much. Open for questions.
Thank you. You explained that really well, mate. Thank you. Because I was reading this and I got a bit lost in the middle of it, but that really helped me. Thank you. What I would like to know is clearly it's great that we've got more people reporting now. There's an issue in the system that's being worked on, and I can hear that positivity from you. But I suppose I'm just really wanting to get what is your level of positivity about that being resolved quite quickly, because presumably it's continuing. So next quarter we'll get a similar, if not more, as more people realise that if you raise an issue, someone's going to deal with it. So how is that going? What's your level of optimism on it?
So my level of optimism is high, but in terms of the time that it will take, I suspect this is a longer game. In that this is a culture that comes in our postgraduate and training, not only from our own organisation, but the organisations that they work with as they rotate through their training. And that can be hard to undo. Nonetheless, there is a huge amount of work going on with the trainees in terms of improving their confidence in the system and together with medical workers in terms of the specific issues that have been raised in this quarter including before, rota changes will reduce the number of executive reports in terms of breaches of rota requirements. I will be hopeful that will be introduced for our August rotation, certainly no sooner than that. It'll be interesting to see what impact that has when we look at that quarter.
So just taking on board that, which is a really interesting reflection about people moving around and haven't registered. But does that, because we need to undo maybe where people don't speak up to us now where people will want to speak up, would we expect to see a reduction in the number at the point of rotation?
I'm not sure we can say that from what we see in the data. I think certainly the trainees who are more familiar with our organisation, who rotate within the trust and those who move on to other trusts, do seem to be anecdotally more confident in raising concerns. And the trainees who stay with the organisation for longer periods as well. So we do have some doctors who are only with our trust for at the time, the more junior doctors. And certainly what we find is they are much less likely, there are no reports by those trainees in the exception reporting, and it'd be interesting to get a better sense of why that might be.
Something that, with support from, or we have asked for more trainings from August, so we are expecting, so hopefully that will help reduce the waiting shifts and also the workload for some of our trainees who are most of those shifts, so that's positive. I think the challenge for us is that we may have to move some of it to a shift system where someone has to come and when trainees have got used to working from home.
Right.
And that's the discussion that we're having now, but that may be the only way to manage not having,
That's the 5 hours
so
issue. Right.
we're trying to work with them, and I think she understands the discussions and
It's just interesting to see, the increase in fines, because obviously the breaches are taking place. It's a bit worrying. It isn't so much the fines for me; it's about the well-being of the doctors not getting their sufficient breaks in time. But hopefully, be able to address that and I'll bit along in terms of the establishment gaps, so many vacancies as well, and what pressure that's actually with. But now that it seems that you're reasonably confident going forward, that will be addressed.
Absolutely, I think certainly a change in the working pattern, potentially for a full shift, will benefit in terms of safe working hours and increased rest built into their working week and remove that pattern rather than being expected to work a full day and then overnight as well. But in terms of what that will actually look like in practice, remains to be seen.
Thank you very much. Don't think there's any other questions. Okay. Just a little bit running behind slightly, so I'm going to really detail the remaining reports now. The integrated performance report, you will have all seen that report at your committee. So unless you've got specific questions, Dave, to ask him, I'll open it now if there are any questions, but you will have all seen this report. So are there any questions? Is there anything you specifically wanted to?
I think that's what we've already talked about, is starting to bring, I suppose, a triangulated report from the individual service areas, registered clubs, the other day, and the sectors. So over a period of time, that gives us a more rounded view of the area. That's the thing that will be helpful to understand and habitat, give it full explanation.
Okay. No questions today.
No.
Okay. Steve, are you picking up Jill's papers? That's the updating action plans arising from Dave. David.
Yeah, it's me.
I think that's just a verbal update.
Yes, it's just a verbal update that from the previous forward plan we had for last year, we didn't have board oversight of action plans arising from external reviews, from CQC visits, from external visits and all of that. So we try to pull all that together onto a single spreadsheet so that it's a single version of the truth that the board can see once in every 6 months. We do the same as well to external visits as well, because some of the visits can really provide us opportunities for learning as well. So those are the two. And then we also look at externally commissioned reports that the board needs to be aware of as well. We're making sure that some of those reports are externally commissioned. The board needs to be aware of, as well as they can monitor the implementation of related action plans as well, and get assured that they've been adequately implemented. So we've had a couple of meetings and we're putting all of that together into 2 spreadsheets, which the board can really monitor.
Very fine.
So this was these items were to inform us of that.
Yes.
Okay. So you'll give us a timeline for the.
That's right.
Right. And the housing policies, first.
Presentation registration.
We would be on the 20
All right.
Yeah, you did the recognition.
Thank you.
Thank you. We'll be as long as you know today, I'll say.
Yeah, I think sorry. Yeah, just one quick element. On the grounds that we already doing the evaluation of the board effectiveness or committee effectiveness at the moment. Emails have gone out to members of the board and members of the various committees who are both members by terms of reference and regular attendees, so that they can complete the survey. So I'm just appealing to this matter.
Yes. I have to speak about the relationship you want to bring to this channel. Well, members. My magic. Yes. It's very good to see you.
Thank you. So I'm here to present the reader the update on health inequalities and the approach generally. The paper is read in terms of time. The paper outlines key themes that are coming up in relation to the work that we've currently been doing. Also, the layering in relation to the national framework and the LPO work which has been locally implemented. It also aligns with the approach in terms of discriminatory organisation in relation to what that means in relation to specific health inequalities, reducing health inequalities. It's got a significant amount of detail in it, and hence not going through every element. I'm happy to take questions and points of clarification, but essentially we'll be doing this update every 6 months so that it does raise the profile of the work that we're completing, but also gives us opportunity in terms of the advocacy of the work through board comments and try to highlight how it intersects with everything we're doing on a daily basis. So happy to take any comments, feedback, but also any clarification.
Yeah, I think it's really helpful report to bring everything together. I think it still raises quite a lot of so what questions for us. And so, and I think one of my main questions about how we are socialising this more generally in the organisation. So if I look specifically around the mental health data, for example, we've had that data for a long time.
And it's one way for us to receive it and to see that we're making progress and where we're sitting at. But it's another thing for our clinical teams to receive it and to understand that there's an expectation around thinking through how they make an impact in this. So I'm just keen to understand a little bit about how we see that, those pieces, how this is becoming the reality for many in the organisation.
I agree, we need to do a lot more. As of now, we do discuss it in detail at key presence of our governance, and then we, have carried down that route to one. So there's also been specific work done on that, the CTO evaluation, which I think we can present in the next report. So that's really going to be very rich in terms of data on qualities, but we want to extend that distribution as well. And I think it's sort of like, this now we've got a framework. Now we're going to start it from here. And with the support of the board, we go to all committees, periodically talking about this. And then what we've done is also looked at good practice across the trust and tried to bring it to a centralized point. Because what we found is that there's a lot of good things happening, but no one knows about it. And then we centralize it and we can put it to report and cascade it again. So it's a start of a really sort of ambitious work, but it's something we have to do, and we need to do a lot more.
On to that point also, I think, yes, we have data, we've not been using data. It's, I don't think we can undervalue that principle in terms of the amount of groundwork. Because of the fragility, no practitioner got schools on intentionally or unintentionally. Nobody comes to work to do that. I think that's a really key point in terms of getting people confident in using the data to then challenge their own practice. So we can't do that without the intersect of the anti-racism framework. So actually, what does it mean to be an anti-racist practitioner? What does it mean to be an anti-racist colleague? What does it mean to be an anti-racist leader? That layered on with the piece of work around patient safety, actually all the demographic data we've recorded, and that is formulating the foundation of the piece of data sets that we look at. That then layered with the data with dignity sessions that colleagues have now started kind of really taking seriously the different level, then layering that down when we're going down the front operational team. So I suppose it's not one trick for me, put around that, but it's a number of different things coming together, but then going with that confidence around this is the data, so we can impact on the data. So what does that mean for you?
And I can see in these transactions that there's a huge amount of work planned and actually happening around that. But it's just that I think we've all got that. That's not very specific, but we've all got responsibility to through the committees and through the work that we do, through the visits that we do, through the connections that we have with the teams around. You ask people how they're looking through this lens and this work. Can I just say, if I may question Karen, I suppose one of the things that won't be jumping out is how impacted positively the national team when it came to the launch. So we joined this as a part of the pilot, but we also joined knowing that actually that sections have been doing something for a long time. And we were coming at it from trying to pull together our work streams and we bring our actions together around it. So both the national lead and the national clinical lead and Professor Jackie came as part of the launch, and it was really powerful to hear their feedback and their impression of how much progress they thought we'd made in a period of time. So all the credit to yourselves, but teams that also work with that in terms of so. We were able then to share that in a number of forums. So we shared that with all the mental health trustees in England and in the Midlands. And so I think it's another area where at the moment we're being looked to help support, lead the way on a national requirement, but the way we've gone about it is around 3%. And we've gone about it by saying this is something that supports us in our
anti-racist training and anti-discrimination. So I just wanted to really highlight that. How really important it is.
Thanks for saying that, because it's given us a boost to the teams and the co-production and our patients as well. So it's really helped to get that feedback directly from the national.
Yeah, that is really great. Yes, thanks for the update. It's really great to see the this sort of the plan maturing and start to see the outcomes. But my question was, and apologies if it's in the data here. We're looking at it from a health perspective, but there's a lot of data there around the general picture of the population. What are we doing to actually work with or engage with public authorities, so councils, police, who have an equal stake in sort of improving the sort of the health inequalities and general economy of the region?
So, sorry.
No, specific.
So some of the groups that we're active parts of in people of colour and equality group that's actually led through the ICP lens, I think it is. Some of those relationships, I think everyone can actually developing local relationships, especially with the pathway around the Mental Health Act and actually roots in. So that is something that we're proactively working on at the moment in relation to the police and local council, but not reducing the impact at those group levels that are already there. But also through the ICS lens, the organisational development group that's created there, influenced it to be inclusive of not only police and fire, but also ambulance services and council, which previously we weren't looking at it through that lens. So any learning that we're making locally, what we're trying to do is influence upwards and across as well, so that we can all collectively share that space, but also really reinforce those local relationships and the pathways that we are really interested in terms of those high impact actions.
That's great. Could I speak to a public health agenda? So it'd be really great to see this.
That's about how population management and health inequality how they do take together. Maybe socially, that's kind of what you were saying. Sorry.
Thank you. Thanks for the update. I suppose, and we're short of time, but it would have helped with if it had been presented, I think, because there's probably something around some of the slides that give them, would help me understand them a little better.
Yeah.
And I suppose but the key thing that worries me slightly is that there's the last slide sort of suggests that might have been issues that we should have been discussing. And I don't think we've probably got time to do that here to help you through some of those, or to understand what our contribution to be in terms of resolving those. So I was just wondering how we're going to take that forward, because to me that feels like, thank you for coming, we haven't got time, but we haven't quite done the bit of work that you wanted of us. That would be my reflection.
I think it's an opportunity through one of our strategic
Indeed.
sessions. So this is a big subject. So and this is a big ticket item. So
Yeah. That's fine. As long as we do know that when we're going to get to it, that's
Yes. Yeah, that's all great. Really helpful slides, just around sort of priorities. So we talked about population. Consider building on what we've done around the priorities so that we understand what our reality is as an organisation. So for example, when we talk about physical health or reducing inequalities, through which what we've done, we went forward to say the actual proportion of being interviewed and being appointed is this. If you're from this particular characteristic, could we start to do that so we understand our reality? So when we talk about the mortality rates, depending on where you need Birmingham, Solihull, that makes it a reality.
Yeah.
So if we know that the point of someone being restrained if they're in a particular service is helpful for us to be able to understand what it is that we need to be dialing down. So it's just a way of building on what we set out as the priorities and being clear on what our reality is as an organisation.
Excellent. Chav, as always, excellent piece of work. Something like I said to Jean earlier, just dovetailing on that. I suppose what the organisation wants to hear is not what we are against, but what we're for, is the evidence of some of the initiatives and activities which we want to take. And the things of that, that's absolutely so it's focalising this information, disseminating it out in terms of to the organisation and wider, actually sending a very clear message that we place this as a significant high priority as it is. And so, I commend you how you're going to do that and how we do that and get that all out there. But I'll leave that to you. But really, it's vitally important because that's what people want to hear. They don't want to hear what we're against. What are you doing about it? And we've got lots of initiatives as well. We've got so many different things which we are doing, and we're slowly seeing green shoots. But it's ensuring that this kind of information somehow, and the data that Patrick's just spoke about, localizing, breaking it down, will reinforce our, not just our efforts, all of our energies are actually put behind making that difference.
It makes me wonder about whether we should be planning to hold a conference. That's exactly what we do. So, that gets the message out loud to the customers, but wider as well. So that's what it's about, the process of how we negotiate this. And I think it also fits with us particularly. Yeah.
I think that's right. I think, there's a lot of skepticism out there saying, oh, we've heard this before, what's probably happening. I think the confidence that you can send out a message and to those who are going to groups that are interested in this area as well.
Yes.
About us reaching out to them and bringing them in, that's just being ourselves in line and it really good.
There's an action for each other, not just for you.
We'll find people that it does.
It won't just be what happens to me, but thank you very much. Really fascinating this and the progress being made. Thank you. Welcome. So, okay, so if I'm jumping around a bit just to make this very quickly. Steve, the HSC and NHS letter and report. Was about information and notes, yeah, with it. Thank you very much, sir. David, there's a number of documents for noting. Yeah. There's the ratification of the trust constitution and associated documents, and that's incorporated in the standing orders and the commissioning committee. It's come for the board.
It's got a noting because we have already the more than ratified and you are completed. Yeah.
That's great. That covers everything other than say that our extraordinary board meeting on the 21st of June is from 2 till 2:30 thereabouts. And that's just to ratify the annual report and the accounts of 22-23. Yeah.
I have commented that gives some of us 15 minutes between meetings.
It does.
On either side. Yeah. Which is not a long time. Than sitting in meetings all day, is it? But anyway. It's not just me, there will be exec colleagues who have been in.
Yeah. Can we just take that outside this meeting to see how we could address that in any way possible? You
can't really make it down. It's up to us.
We didn't manage to hire any of the meetings on time this last month. So we need to bear that in mind. So
We need to think whether we need to sort this at just the top of the day, or something, but we can have a discussion.
anyway,
Afterwards. Okay, everyone, I think that's it. Before we just break for lunch, in part two, I know a couple of our colleagues do need to leave well at 1 o'clock. So we just need to let them know. Do you want to have a break now, or do you want to go? Oh, what's that? Sorry.
Well, it's a more than anybody probably want to. Oh, she's I mean, all I say, you know, the Roshin Chair, Birmingham City Children Trust, it's a great news. Maybe it's a ripple effect can happen to us. Just want to say, I mean, your Roshin, your leadership from 2019, board has been formed this one, helping the trust to develop clear strategy and vision with a leader who is passionate about positive change and improvement. And Lorraine, who's a CQC, Midland Operational Director, said, and understaffing was a big concern. And while many NHS services and those in the wider care sector are facing staffing. Challenge to our trust must find a way to minimize the risk, this is the risk, to people in the care. That's my question. And I want to congratulate and CQC mention our staff treated patients with compassionate and kindness, understood individual need of the patient, the staff actively involve patient and family carers in a care decision, and they follow the best practice, anticipating, de-escalating, and maintaining their behavior. So I just wanted to share that and ask you, non-executive, and what you, it's like learning from city council. They are from different government, they're different color, but despite the budget, they have done something, and we should celebrate it as a city for doing that. And maybe next year, our CQ report maybe from could be good, or that we can celebrate at the wider community. I just want to ask.
And I think that, you know, the learning is that people work with teams. So I think, you know, that huge team effort. So, you know, thank you for your compliments, but actually it's, you know, it's an absolute a team effort, and that's definitely the learning that we need to Andy Coldrick who led, that he would say, this isn't about him, this is about how there's a team effort around this, and about relentless focus. So that, you know, setting the strategy, being really clear about the fact that all that you do sits around that. And if it doesn't, then why are you doing it? So I think that would be the kind of things that he would say about that, but also about having really good partnerships. So that so that teamwork isn't just about in the trust, it's really about the partnerships and how they have developed and supported the work as well. So there were probably three things that I think are good learning for us.
Thank you. And just before we just end this formal board meeting, just it was already referenced in the Sheens report, just wanted to note it again, which is a congratulations to Fabida for being accepted as a fellow at the Royal College of Psychiatry.
Nice to see that. Thank you so much.
Excellent. It's always good to acknowledge our colleagues who are actually representing our organisation for doing great work. Patrick was another one who sat on the panel. HSJ, I think. You haven't done it yet. Okay, so that concludes.
Do we think we can be quick?
The Penny vote, can we be quick and just do that in part 2 board, then that will conclude everything, and we'll just have the vote this afternoon.
Yeah.
Yeah.
There was a content. I need to get something to read.